I hope this is the right lecture. I think this is the second one. Risk stratification in heart failure. You've already heard a wonderful lecture by Dr. Franco, and so some of this I'm going to go through quickly, as you've already seen this information. I want to put in context some of the information that you've heard this morning related to advanced therapies, LVADs, and selection. I think the big challenge that we have is timing. In other words, I can identify a patient that I feel needs a transplant, but we can't get a transplant done because of lack of donor hearts. So this really puts the challenge on the medical team to figure out the best strategy to keep the patient alive, the best strategy with respect to an alternative procedure, maybe a high-risk bypass and a valve procedure, maybe a MitraClip procedure, et cetera, because transplants just are not available to us, I don't think, anywhere in the world. At this point in time, approximately half of the patients that receive a heart transplant in the United States are on a left ventricular assist device. The waiting times have grown dramatically. At the Cleveland Clinic 6 years ago, our waiting time was less than 2 months. Now our waiting time is over 14 months. So when I look at selecting the right patient at the right time, we always have to try to determine who's the sickest. The patient on ECMO, that's easy. The hard patients are the patients with chronic heart failure that are in our clinics. And again, this issue of risk stratification is put in the context of advanced therapies, standard therapies, and I'm sure everyone now pushes the envelope with standard therapies, and surgeons are doing operations with trepidation only in the context that some of these other procedures, whether it's an LVAD or a transplant, are very difficult to get done, either because there's concomitant right ventricular issues or donor shortages. I think where we have lagged behind in the United States has been our approach to managing patients based upon their risk with palliative care and really actively engaging patients and families in end-of-life discussions. So you saw a approximation earlier about how many patients actually are in need of transplantation. And this is something that we published a few years ago, taking adults over 20 in the United States and parsing this down to look at those with systolic heart failure, and then further parsing it based upon advanced stage 3B or 4 or stage D heart failure. And even at stage D, the approximation is as low as 15,000, as high as 156,000. And we estimate conservatively there are 100,000 patients in the United States that might benefit from these advanced therapies. And again, there's our challenge. We only do 2,100 heart transplants. You've already heard the definition of advanced heart failure, and it's an ability to exercise, a reduced functional capacity, either the 6-minute walk, and you've heard a lot of discussion about the peak oxygen consumption. This is the table from the European Journal of Heart Failure with a lot of the data that you've already seen. But again, it revolves around reduced functional capacity, frequent hospitalization, and the fact that every other form of therapy has already been attempted. So again, the challenge that I face every day is selecting the right patient population, when to refer that patient and when is the best time. As far as who is sick enough for advanced heart therapies, I think these 3 bullet points will go a long way to identify a patient in your clinic that you should consider a discussion with an advanced heart failure specialist, many of whom have spoken at this podium this morning from this country. Recurrent hospitalizations, a reduction in peak oxygen consumption, and BNP. And I think that the data on hospitalization is very solid. If you look in this figure here, looking at median survival based upon the 2nd, the 3rd, the 4th hospitalization, it's very clear of the relationship. Another way to look at this is some data that was published by Scott Solomon at Brigham and Women's, and he looked at 2 parameters. He looked at the number of hospitalizations, and he looked at the length of stay. And you can barely see it on this figure, but the top line represents the patients that had been hospitalized 3 times for heart failure and had a length of stay of over 20 days, and their hazard ratio is 16 as far as mortality is concerned. So again, very simple things that look us right in the eye all the time. Frequent hospitalizations, long length of stay, and the biggest common denominator, I think, on those long length of stays revolves around, as has been discussed earlier, renal dysfunction. When the kidneys go in the heart failure patient, you know that you have a real challenge on your hand. This slide, I think, shows very important information. It looks at the hazard ratios for various causes of death after you discharge a patient from the hospital for their first heart failure hospitalization. So what is on the x-axis is time after discharge from the hospital in months, and hazard ratio for all-cause mortality on the y-axis. So the top line on this graph represents a mortality from heart failure. And so this shows clearly that the patient's exposure to dying from progressive heart failure is quite high in that immediate time period after they are discharged. Doesn't begin to level off till it's about 6 months post-discharge. And importantly, and this is probably affected by the use of defibrillators, was controlled for in this study, if you look at sudden death, that is a relatively constant risk after discharge. So the message here, I think, is that you don't have a lot of time to plan a strategy with some of these patients, and frequent and close follow-up is essential. This study was already presented by Dr. Franco, and this is the study from Columbia University, senior author Dr. Mancini, where they looked at every one of these boxes that you see here is a conventional risk stratification tool. BNP, peak oxygen consumption, ventilatory ratio, heart failure survival score, Seattle score, and then box D is what they combined together at Columbia, which was peak oxygen consumption and BNP. So this shows all the ROC curves, the C statistic, etc. And again, you saw this, I've annotated this figure a little bit, but if you take a patient with if you take a patient with a preserved peak oxygen consumption with a BNP less than 500, their survival is as good or better than what we get with heart transplantation. So on one hand, that's a patient you don't want to refer for transplant. And in fact, in the United States now, for an outpatient on the transplant list who is not on an inotrope, they will essentially never be transplanted. So in the US now, less than 5% of all transplants are ambulatory outpatients that are not on inotropic therapy. On the other hand, the patient that has the highest risk of dying is the low peak oxygen consumption, less than 10, and the elevated BNP, as was described by Dr. Franco. This is some data from the Cleveland Clinic that we published 6 years ago in Circulation Heart Failure. It recapitulates what has been shown by others. So we had 110 patients at our hospital that were discharged, and it just happened by chance, 55 on dobutamine and 55 on milrinone. And the take-home message here is if a patient is on chronic inotropic therapy, their mortality at 6 months is about 50% and close to 100% at 1 year. So it is becoming common in the US now for patients with a defibrillator to be discharged from the hospital on inotropic therapy to wait for a transplant. More often than not, if the patient is deemed eligible for an LVAD, and if that patient is felt to have a long waiting time, we will definitely refer them for LVAD, but many patients do not accept that additional surgery. INTERMACS you've already heard about, and I just want to mention INTERMACS from the context of risk stratification. When we developed these INTERMACS levels, this was based upon the recognition that NYH class 1 through 4 is a relatively old and crude tool to risk stratify patients. For that reason, these 7 different INTERMACS levels that had more granularity as far as the functional capacity of the patient were developed. In addition, not shown here, well, if the patient has problematic ventricular arrhythmias, this is an additional modifier that can be put on. And so we are now starting to use INTERMACS levels within heart failure registries in the United States to see how well they track with mortality. And the preliminary information that is coming out of some of these registries is that it provides much better predictive capabilities than NYHA class. The other thing I'll mention related to INTERMACS 4, this is an ambulatory patient population, not on an inotrope. In 2 weeks in JACC, you will see a publication called the Roadmap Study, which is a series of patients that were implanted with an LVAD who were INTERMACS 4 or higher, not on inotropes, providing some of the first data on is there an advantage to implanting an LVAD earlier in a non-inotrope dependent patient population. I'm not going to tell you the results. You're going to have to wait and read that paper when it comes out. It's already been presented publicly last April. So finally, how do you determine the risk of mortality or hospitalization in an individual patient? The really sick patients are easy. I would submit the chronic heart failure patients are more difficult. Sometimes we resort to looking at hemodynamics because it can be very sneaky when you see a patient with chronic heart failure, just how sick they really are. I think getting a functional test is essential. Hospitalizations is a big clue, and risk models are helpful. This is data from ASCEND-HF that developed a mortality risk stratification. This is exclusively in patients admitted with acute decompensated heart failure to the hospital. And I think there's probably no surprises that this particular risk model found that BUN, baseline level of dyspnea, increments of systolic blood pressure less than 120, age and baseline serum sodium were the most important predictors that came out of literally over 100 variables that were looked at. The predictive value of this particular risk calculator, the C-index, was 0.745. The other thing we saw in ASCEND-HF was if you looked at 180-day mortality, the blue line are the patients that were not readmitted within the first 30 days. The red line is the patients that did have a readmission in the first 30 days. And again, this particular study, which had thousands of patients from around the world, showed the message that if a patient's readmitted in the first 30 days, they're at high risk. You've already seen this information on the Seattle score, and I just want to close with this information from Dr. Aronson, who's a heart failure specialist at the University of Michigan. So a C-index is a measure of discrimination. 0.5 is a coin toss, 1 is perfect. Bear in mind, most heart failure models, it's less than 0.8. Shared decision-making with the patient, the family, and the physician is really the key. And as I agree 100% with what Dr. Franco said, we don't use these tools in isolation. They're used to enhance clinical decision-making. We have a committee at the Cleveland Clinic that meets weekly to discuss many of our patients. And this is the room. There's a few familiar faces, perhaps, to some of you. On here, Dr. Soltesz and Dr. Smidera, two of our surgeons, are in the front row. But there's a quote here, and I'm going to just read a little bit of it, because this is from a paper at the Cleveland Clinic that was published by Dr. Smidera and Dr. Blackstone. And basically, it's talking about the Euroscore, Seattle heart failure model, other preoperative scores, and it says, these in our cognitive prosthesis tool are not meant to replicate or replace surgeons' cognition, I'll add cardiologists to that, through prediction models, but rather to synergistically augment and extend their capabilities. Thank you very much.